We'll kick off our first session. Our first session is titled Revisiting Preventive Visits for Women as the Title V National Performance Measure and a Unique Opportunity. For context, this session will be about how the Maternal Child Health Block Grant got started as a program. This is a federal state partnership with the goal to support health and well-being for all mothers, children, and families. Several years ago, a new national measure was introduced. It was called Increasing Preventive Visits for Women. This session will offer a quick overview and some status updates. Then the speakers will share some ideas about innovations underway that will support a sister measure, which is called Increasing Adolescent Well Visits. The group will then talk about opportunities for innovation and leadership in this space. Now, I'll pass the mic to our panelists so that they can introduce themselves and get started with this conversation.
Hi, this is Keriann Erisugi. I'm sorry, I lost my full screen. Do you want me to just do my slides or let Mch introduce themselves?
Perhaps you can introduce yourself and Team Mch can introduce yourselves, and then you can jump into your slides.
Hi, my name is Keriann Erisugi. I work for the Maternal and Child Health Bureau and the Division of State and Community Health, which administers the Title V Block Grant Program. I am a health scientist, mostly responsible for putting together the federally available data, which includes the National Performance Measure 1 that I'll be talking about in a minute.
Hi there all, my name is Andria Cornell. I'm the Associate Director for Women's Infant Health at Mch, the Association of Maternal and Child Health Programs. It's a real pleasure to be with you all today. I'll pass the floor over to my colleague, Giannina.
Hi everybody, my name is Giannina Ong. I am the Maternal Health Program Associate at Mch, and I'm happy to be here today. I will pass to Kristina.
And greetings everyone once again. My name is Kristina Wint, and I'm the Program Manager for Women's Health, also at the Association of Maternal and Child Health Programs. So happy to be with you guys today. Back to you, Keriann.
Thanks, Kristina. I'm gonna share my screen now. Okay, so today I'm going to be giving you a little bit of background into NPM1. There we go. So NPM1 is the percent of women aged 18 through 44 with a preventative medical visit in the past year. This measure comes from the Behavioral Risk Factor Surveillance System from the CDC. This measure is also shortened to often well woman visit. And the concept of this measure really does encompass related things like pre and interconception care, but it also captures women who are not planning or post-pregnancy. So a lot of the things that we've talked about in this conference in sort of encouraging wellness across the lifespan would be encompassed within this NPM1. Thinking about how we frame it in our guidance for the Title V Block Grant Program, we think of this well woman visit as an opportunity to provide a critical opportunity to receive recommended clinical preventative services, including screening, counseling, and immunizations, which can lead to the appropriate identification, treatment, and prevention of disease to optimize the health of women before, between, and beyond potential pregnancy. So potential, they may or may not have a pregnancy during their life. We do say that this NPM is linked to several of our national outcome measures, including severe maternal morbidity, maternal mortality, a lot of adverse birth outcomes like low birth weight, preterm birth, early term birth, and then as well as various infant mortality outcome measures. It's also related to maternal behaviors during pregnancy, like drinking during pregnancy, as well as substance use, which is operationalized as neonatal abstinence syndrome for the most part. So that's a definition of it. To give you a brief timeline, I want to shout out to Kay Johnson for providing the far more comprehensive timeline of the concept of preconception health. I really did appreciate her talk during the first session, and if you hadn't seen that one, I would recommend you do that. This is far more abbreviated, focused on Well Women Visit as an NPM. You know, to begin with, the Affordable Care Act, passed in 2010, had that focus on insurance covering preventative services, including annual physicals. In 2011, the Department of Health and Human Services commissioned IOM, which is now the NAS, a study on the initial recommendations on women's preventative services guidelines, with a recommendation to update them every 5 years. So that was the first set of women's preventative services guidelines. In 2015, we underwent a Title V maternal and child health block grant transformation, where we created a whole new performance measure framework. And that's when we established NPM1, Well Woman Visit. In 2016, HRSA, which is my agency, entered into the first 5-year cooperative agreement with ACOG and others to update the Women's Preventative Services Guidelines as part of the Women's Preventative Services Initiative, otherwise known as WPSI, which you heard about in the first or second session, I believe. And as of now, we are now looking at updates for WPSI, particularly on the Well Woman Visit. And there is an actual public comment period that people can comment on the draft language for the updated Well Woman Visit recommendation. So how did we come up with National Performance Measure 1? At that time, we wrote about the new performance measurement system. And you can read this paper that's cited here at the bottom, which is a really nice overview of the performance measurement system and sort of the criteria and the thinking around the new performance measures. So I've drawn a lot of these bullets from that article if you want to read more in depth. But in general, Well Woman Visit is consistent with MCHB and the Title V legislation's focus on preventative health services. There was also that emphasis, as I mentioned, within the Affordable Care Act on women's health preventative services. When we were looking very minutely at which measures would be good, we had several criteria. One is that it had to be nationally available with annual data, available to be broken down at the state level, and by various demographic stratifiers in order to identify disparities. That's something that often gets overlooked about our national performance measures. I think if you go to our Title V information system, you see the measures presented for overall, but we do annually break down and provide stratified data for all of our national performance measures as the data source allows in our federally available data source resource document that's also available on our TVIS website. NPM1 also fit in with the life course perspective that Dr. Michael Liu, who was our previous MCHB administrator, was a big champion of, and it's still a fundamental framework for a lot of our MCHB work. It also fit into this new population domain concept where we have 5 population domains: women maternal health, perinatal infant health, child health, adolescent health, and children with special healthcare needs. So this was a very uniquely women maternal health measure. The old performance measures, for those of you who may have been part of Title V pre-2015, we did have performance measures, but they focused on pregnancy. There was early entry into prenatal care and smoking during pregnancy. There wasn't one related to women's health in general. Going back to that life course perspective, another one of our NPMs for the adolescent health domain is adolescent well visit. So again, this is a very nice alignment with Well Woman Visit. We want our adolescents to be getting regular care, and we want that to transition into regular adult well woman care. And lastly, one criteria was that it had to be considered modifiable by Title V activities. So since we've implemented NPM1, we did hear challenges from the states and other stakeholders. Some challenges were that NPM1 or Well Woman Visit didn't immediately align with the existing maternal health activities that Title V agencies were engaged in, such as prenatal care, smoking cessation during pregnancy. Another challenge was identifying the research on evidence-based strategies to improve well women visits. The Mch Evidence Center is a TA resource center focused on helping states identify evidence-based strategies to address these national performance measures. And when they did their evidence review, there was not really any strong research conducted around strategies to improve overall well women visits. So they drew a lot of their strategies from the research related to preventative services, cancer screenings and other types of screening services. So that's still a struggle that I believe is out there. Even if you look at the WIPC background research on well women visits, it's again acknowledged that there's not a lot of research focused on ways to increase well women visit rates. Another challenge that our AmChip colleagues will probably be talking about is this notion of what to focus on with well women visits. When we implemented the measure in 2016, we saw that a lot of our evidence-based strategy measures were related to the quality of a visit, and we couldn't immediately see the connection to how this was going to increase access or increase or be able to improve the national performance measure. And there were lots of questions that have come up related to what makes up a well woman visit, who provides a well woman visit, sort of open-ended questions for states to grapple with. We did hear a lot of these challenges, and in 2018, we made adjustments to our national performance measure framework in that set of guidance. Before, we had a life course domain or a cross-cutting domain, and we still have a cross-cutting domain, but in 2018, it was, we took out all the national performance measures associated with it and redistributed them amongst the other population domains. So we were able to add smoking during pregnancy and preventative dental visit to the women maternal domain, just to give some more options for states to choose different types of women maternal national performance measures. We also reduced the number of national performance measures that were required to be selected from 7 to 5. We made state performance measures optional, but we do require a state performance measure if the NPM is not aligned with the priority need that's identified by the state. We also reiterated that the priority needs should drive the selection of the NPM. One thing we saw in 2016 was that a lot of states just selected based their priorities on which NPMs they could select. One change that we've done in this new guidance that was released in January of 2021 was that we revised the ESM detail sheet, which is the evidence-based or informed strategy measure detail sheet, which now we're asking for states to more clearly define what the evidence-based strategy is. We're also asking states to more thoroughly explain how their strategy and that measure is going to impact the national performance measure. So helping states to really think through, okay, if I'm working on quality of the well woman visit, how exactly do I theorize that will improve the national performance measure? So that's a new change that we hope that we will be reviewing in this upcoming block grant review season. And I apologize for those of you who may be attending that aren't as familiar with Title V or the Title V performance measurement framework. You can always go to our website, which is, I'll put in the chat box at the end of my presentation, and you can read more about it there. Just to give you a sense of where we are currently with NPM1, this is a nice map that the Data Resource Center on childhealthdata.org puts together every year. They present the statewide estimates for a lot of our national performance measures, including NPM1, and they show where that state is in relation to the overall US total. So 47 states selected NPM1 at the beginning of this new 5-year cycle last year. I checked recently with the new applications. States had the opportunity to change their performance measure selection because of the pandemic and a lot of issues that might cause changes in priorities. But the same number of states continued to select NPM1 this year. I unfortunately didn't have time to add the jurisdiction, so I included them there. We had several states who, and I've highlighted it with a red star, who selected NPM1 and their priority need had a health equity focus. So I wanted to highlight that here because this conference is focused on equity. As I mentioned, we do provide the data stratified across various demographic stratifiers. So I wanted to present what the overall disparities look like among women visits. Among race and ethnicity, Hispanic women had the lowest rate of having a preventative visit in the past year. Non-Hispanic Black women had the highest rate. Rates increased with increasing educational attainment as well as household income. The big disparity is between insured women and uninsured women, as well as English-speaking and non-English-speaking women. And there's a slight increase, but the difference is not terrible amongst age. I do want to point out that I was looking back at the Kaiser Family Survey from 2017 on women's health, and the order of which these disparities occurred was very similar for race, ethnicity, educational attainment, and household income. So what is the future of NPM1? Since we just completed our first 5-year cycle in 2020, we wanted to take that time to accumulate 5 years worth of data across our NPMs so that we could evaluate how well the performance measure framework was working, whether or not changes in the states were able to make progress in the NPMs. So that's something that's going to be ongoing over the next year or two. We hope to complete the evaluation so that we can begin to consider any revisions to our national performance measures. We didn't really make any revisions in this last guidance release at the beginning of the year, but if we are making revisions to our national performance measures, that will likely happen for the 2024 to 2026 guidance, 3-year guidance. So that's all I have today. I will turn it over to Andria now.
Thank you so much, Keriann, for that detailed presentation. So greetings all, I'm Andria Cornell. I'm joined today by my colleagues, Kristina Wint and Giannina from AmChip's Women's and Infant Health team. We're really excited to be with you to talk about the Title V National Performance Measure #1 and to enter a brainstorming space. So our presentation is really to give you some brainstorming nuggets overall in what it means to work through this national performance measure. I do want to just acknowledge to Keriann's point, we started today and this presentation in a lot of administrative weeds related to a key aspect of the Title V MCH Services Block Grant. But for those of you that are unconnected to state or jurisdictional governmental MCH or the Title V Block Grant itself, I hope we'll illustrate some leverage points and partnership opportunities with your state health agencies, especially if anything that we share or that comes out of the brainstorming from the expertise of this larger collective participant group is inspiring or innovating. We really are excited to go in that direction. So if the team wouldn't mind pulling up the slides, just a couple more comments on this first slide. I just want to acknowledge, since the creation of this national performance measure, AmChip has had many interesting conversations and provided technical assistance to our members on how to best leverage this national performance measure to respond to state priorities. And much to what Keriann shared, the common thread has always been that there's tremendous variability in how MCH programs actually approach this measure. That variability is good, and it signals how Title V funding can adapt to the priorities of each jurisdiction, but it also reflects challenges in maximizing the potential of the national performance measure and the strategies to support it really from the perspective of advancing access to whole person, equity-centered preventive healthcare. And so really, given that a significant majority of Title V programs select National Performance Measure #1 as a focus, and that we have so much room for improvement as a nation in well woman care, we wanted to share some opportunities we see ahead for this national performance measure. And we'd like to use this space to illustrate some pathways to equity for this measure. So next slide. Right now, when we look across the strategy measures for this national performance measure, we see a lot of strengths, but we also see opportunities for better alignment between those strategies and well woman care, the intent and the actual measure that is encompassed within National Performance Measure #1. In Keriann's presentation, she shared that MCHB prioritized creating a national performance measure on what could be truly modifiable by Title V. And so what we want to underscore here is that Title V has unique power that is different, but complementary to that of clinical partners. There's a flexibility to Title V to fit in those areas where responsibility for our fragmented healthcare system is really unclear, and where we lack joint accountability for systems that ultimately support wellness. Title V is just such a powerful partner. And most importantly, Title V can also be a model for how to lead from advancing health equity and reducing the disparities that Keriann shared. So we know that while the Title V MCH Services Block Grant and the federal state partnership, it's a large sum of funds, it's finite, and it covers a large population and a vast array of work. That finite amount of funding, yes, only goes so far, but at the same time, the partnerships that state and territory MCH programs have are just so extensive. And so there's that power, not just in the funding, but power in the relationships that Title V has the opportunity to leverage. So in the space of considering unique roles for Title V, our team, we wanted to share some just exploratory conversations and considerations. These aren't meant to be all encompassing. They won't cover all the wonderful concepts that have been shared in the first 2 days of this convening, but they're meant to kind of keep us in the space of innovation, going upstream together, to use a phrase that Dr. Warren uses often, and just to enter that space of exploration together and see how we can release some of that potential of this national performance measure and the strategies that can be implemented under it. So with that in place, I'm going to now pass it over to my colleague, Kristina, to bring us deeper into the space through the next slide.
Thank you very much, Andrea, for setting up that context. As Andrea just shared, we want to spend our time today grounding our conversation in 4 questions. And we'll be using examples of evidence-based or evidence-informed strategy measures to go deeper into each of these questions. And so they're on the slide, but to share them out loud with you all, we want to explore who is providing well woman care, what is, or rather, what do we mean by access? Really thinking and expanding our minds beyond geographic access. We want to think about what is an equitable approach to family planning. And lastly, we want to think about how Title V can leverage the state performance measures and the cross-cutting domain to advance equitable and person-centered wellness. As Andrea shared, this really is a brainstorming space. We're going to kind of talk through some of these questions, but we really encourage you to join us in this discussion in the chat and to respond and to share your reactions and your responses or further questions that will pop out to you as we have this conversation. If we could go to the next slide. So the first question, who provides well woman care? So when we look across the evidence-based measures, we see references to a wide variety of providers, all providing one aspect of care, be it family planning or behavioral health screenings. But there is quite a bit less emphasis on ensuring that people who are assigned female at birth are receiving comprehensive care that is captured by the well woman visit. And so we want to ask ourselves, who can provide this care, this comprehensive care? And who do women and people assigned female at birth trust to provide that care? And as we think about, comprehensive care, we're also thinking about quality care. If we can go to the next slide. And here are just some examples of ESMs that kind of encompass this. And so first here we have the number of women ages 18 through 44 with a past year preventative medical visit in a state health department local health unit. Another example being the number of behavioral health providers trained in pregnancy intention assessment. And when we think about, these measures, and then also, what is comprehensive care and who is providing that, we want to think about and consider, what are the resources that are already being invested in, that are already being seen? Where is the focus on providers and the folk who are already funded? How are the ways that we can reach other people, both patient and provider? It's also important for us to think through, how can we lift up, various types of providers, thinking about federally qualified health centers. When we think about the midwifery model of care, and midwives, a great example, because they are providing care across the lifespan. When we think about other forms of nurses, family providers. How are we supporting these types of providers? How are we reinvesting into community so that they can have a community of providers around them? Next slide, please. And this next question is about what is access? And again, expanding our minds beyond geographic access. We often think about healthcare access as really being geographic, thinking about transportation, maternal health deserts. But there are a number of factors that really impact people's abilities to access care, but also to want to access that care and to feel safe accessing that care. And so we pose the questions of what resources exist in a community with a healthcare provider shortage. If there is nowhere to access, your primary care, how can you leverage what resources you have to ensure that you can remain healthy and stay healthy? Where does cultural congruence and respect fit into the concept of access? It's one thing to say that there is a clinician or provider within your neighborhood or community, but is that provider culturally humble? Do they have an understanding and respect for your cultural practices, for the choices that you make? How do we lower barriers to access for these appointments? And this is a very important one because, again, often when we think about access, we're thinking about geographic. Is there a provider in this neighborhood, in this community? But we also need to think about, the transportation, the childcare. Are people able to get off work in order to make the space for an appointment that may, start late and run long? How are we providing access and lowering the barriers for these types of appointments? And also, are you able to build a trusted relationship with your provider? Are you able to receive continuous care with them, to talk with them, for them to get to know you and you them, and to really trust them with your health? Next slide, please. And the ESM example that we have here is the percent of family planning visits that occur via telehealth at pilot sites is what we saw at a state. And this is a great example because telehealth has really expanded how care has been able to be provided, especially over this past year, as we think about how many places are flexing and reacting to the pandemic. However, it would be remiss for us not to think critically about the limitations there are to telehealth. For example, it's not possible to do a pelvic exam or a breast exam via telehealth visit. And so really, is this, the true solution to, increasing access to one-woman care, or do we have to continue to expand and flex and think about how we can decrease the barriers to people accessing this type of care? I'm sure some of you may have even experienced over this past year with the spread of telehealth that there's a wide disparity in how people are able to access broadband or fast internet. If they even have, a device with a camera on it, a high quality camera where they can talk to and actually interface with their provider. If they, again, have the time to step away and take it to have those conversations. And so these are all the things that we continue to want to prompt you all to think about, and that we want to continue talking about as we think through, what access looks like, how can we decrease the barriers to access, and what we can do. And I want to pass to my colleague, Giannina, for the next slide.
Thank you, Kristina. I want to talk about how we can equitably include family planning in this, because I notice a lot of ESMs throughout the states include family planning, and I want to think deeply about, considering racist histories of birth control devices while we, provide the best care. So one thing that I want to think about is emphasizing listening to patients and their preferences. In particular, if we are uplifting autonomy, like patient autonomy in birthing spaces, we should also uplift that same autonomy in all patient interactions. But unfortunately, we still find some family planning providers and even general practitioners who provide, counsel about birth control that doesn't respect patient preferences. In particular, sometimes, providers may choose not to hear women and those who are assigned female at birth when they declare that they're using contraceptive methods that are not a LARC or a medication. So, things like the rhythm method or things like condoms, like they may not choose to hear that, and they may ask, like, would you like to use an IUD instead? I think that we really have to counsel, our providers to be more patient focused and oriented. Next slide, please. This is an example of an ESM, and there were a bunch of these that look like this. So it says % of family planning clinics that have LARCs available. And then another one is number of LARCs utilized among women of reproductive age served in local public health departments. So yes, thank you for that. Long-acting reversible contraceptive is what a LARC means. We know that modern LARCs, such as IUDs, are safe and convenient options. So we should continue to promote them to women who want to access them. But we also have to recognize that the origins of the IUD lie in a eugenic effort to stop reproduction in developing countries. So with that in mind, there is lots of hesitancy about the safety and things like that. So I think promoting an environment where you can talk openly about that is very important. The second point I want to get to is, like, we put so much emphasis on birth control, but I'm wondering how often are general practitioners and family planning providers talking about plans for starting families? Because of racism, Black people and people of color experience weathering and allostatic loads that, means that these BIPOC patients carry the weight of more health complications. At what point, like going back to the first point made about like equitable family planning, like would we consider a Black or brown person healthy enough to start a family? I think that that's a really important point as well. So not just thinking about, controlling who gets to give birth and reproduce, but also thinking about like, how can we enable them to achieve their goals and what they see their family, the family they want in the future. So yeah, I am going to pass to Andria to talk about the next point for the next slide.
Sure. So thank you, Giannina. So the fourth question that we just wanted to pose to the group for thought is how can we leverage the state performance measures and the cross-cutting domain to advance this equitable whole person preventive care and wellness. This is a place where we've seen some really interesting and exciting work. So first, Title V programs are using their state performance measures to reduce silos and create some continuous programming to really think about reducing the fragmentation that we see that women experience in the healthcare system and individuals assigned female at birth. We're also seeing that in the cross-cutting domain as a space to tackle systemic oppression. And I'm using the word systemic oppression very intentionally because it actually is a word that we saw show up in some state action plans in the cross-cutting domain, which is exciting and really, really important. So we've seen some good connection here to embedding, addressing social determinants of health or undoing racist policies and programs in these specific areas of the block grant annual reports and applications, and in the work just overall that have been supported by Title V. One other place that we've been seeing some promising efforts is where states and jurisdictions have been really intentional in disaggregating their performance data. So national performance measures, state performance measures, and their evidence-based or evidence-informed strategy measures at a minimum race, but by other marginalized identities and the intersections of those marginalized identities to understand the impact of efforts on inequities, including if the strategies they're using, especially those documented in the evidence-based and evidence-informed strategy measures, are having inequitable impacts. So there's an intentionality that we're starting to see among the block grant applications and reports to disaggregate performance data and then to actually report on and assess the changes in performance based on some of this disaggregated data, which is really quite exciting. On the next slide, I just wanted to share a couple examples that we're seeing in block grant applications. So for example, a priority need, improve health equity by addressing community and social conditions and reduce environmental hazards that impact infant and child health outcomes. So the percent of performance measures, a state performance measure aligned with that is the percent of state performance measures that include at least one strategy focused on social determinants of health, at-risk populations, or health disparities. So some of Kristina's comments talked about reducing barriers to access, acknowledging social determinants of health have a large role to play in there. So this is an opportunity or an example of leveraging some of that thinking. An additional priority need from another state was improved health equity and reduced maternal, child, and adolescent health disparities, just overarching priority need, with the state performance measure of disaggregated, but percentage of children. So this was focused on children, but this is actually talks about healthcare providers and their families overall. So this could absolutely be adapted for women and for people assigned female at birth, but the percentage of children aged 0 to 17 years who have a healthcare provider who is sensitive to their family's values and customs, or the percentage of new mothers who have ever experienced discrimination while getting any type of health or medical care. The hope is to actually apply and think about how we can gather the same information and measure similar information in the populations that we serve outside of pregnancy, childbirth, and postpartum, but in the context of their families and outside of their families. All right, and on the next slide, I think Giannina is going to take us home here with a few last comments, and then we're really excited to hear your ideas.
So today we shared a number of examples of strategies that point to opportunities for deeper exploration of the opportunity that Title V provides to advance equitable preventive healthcare. There's some really promising and exciting examples also that we saw among the state ESMs, and we want to lift those up and celebrate them as well. So on this slide, the ones that we highlighted were like number of women who receive preconception counseling and services during annual reproductive health and preventive visits at family planning clinics. I particularly like this one a lot because I think it attends to, the systemic racism and systems of oppression that we see. This one is percent of reproductive health family planning agency training attendees who report a practice change after completing implicit bias training. And then another priority need that we spotlighted is just supporting and affecting system change by promoting policies, programs, and actions that advance health equity, address social determinants of health, and deconstruct these systems of institutionalized oppression. Next slide, please. To close out, I just want to say that AMCHIP is so excited to be a resource for you in your work maximizing the potential of National Performance Measure number 1. You can find our contact information right here. We're also very excited to learn from all of you about the strategies you are exploring, especially now that Title V programs just submitted their Title V block grant applications and annual reports. So please don't hesitate to reach out to any of us.
So I'm going to jump in because I'm really excited about the potential of Title V. I think, as we mentioned, this is Title V programs are national. They have potential for major influence and major innovation. And we really would love to hear from you, either your response to some of those questions or some things that you're doing. But I wondered, Andria and all, do you want to check in with Rio? See where her drawing is?
Sounds fun. That'd be great.
Hi, everyone. My name is Rio, and I am your graphic recorder. And perhaps this is a good time to sort of orient you to some of the themes that I've been hearing and what I've been capturing. So you can see my screen. I know it's a little blurry, and you might hear a dog in the background, just as a heads up. But really at the top here is the orientation that we received, where first well, not first, but Andria gave some context setting about the power of Title V, where there is flexibility. There's not just funding, but also relationships. And the flexibility and variability to fit into and support the cracks in the fragmented system. Then we heard also from Keriann about NPM1, some of the history and the adjustments, and really what I took from that, given the context of this conference, is that it's for women who are thinking about preconception, interconception, post-pregnancy, and also women who are not planning on pregnancy. It's thinking about the whole woman's health. And I also wanted to flag, for those of you who aren't as familiar, one of the invitations that we received was, if you're not familiar with Title V, you can use this time to listen for leverage points and partnership opportunities with your state agencies. And then down at the bottom were some of the things that I was capturing from the AMCHIP team as they invited us to think about these 4 questions around who provides care, and really what does that look like? How can we support and reinvest so that there is a community of providers around women? What does access look like beyond geography? That could be transportation. It could be working in a job where you can take that time to go to an appointment that might run late. If you're doing telehealth, do you have access to the internet? Do you have access to culturally humility, to providers with cultural humility? Next, how can we equitably include family planning in these conversations? And this is around listening to patients and their preferences, enabling, not just controlling, providing a safe space to talk about the history of contraception. And then finally, how can we leverage the SPMs and cross-cutting domains? And really what was coming out here were ways to actually use this to look at systemic oppression, not just look at, but address, and look at the intersectionality that occurs in folks' identities and ways of being in the world, disaggregating data and getting into some of those more specific ways to actually do this. So that is what I have been hearing and capturing, and I will keep adding to this. And I'm excited to listen to participant ideas, questions, conversations that come up. So I will hand it back to Sarah.
Thank you. So something this is making me think about are some systems kinds of work. I'm curious what some of you have seen different states doing that might be, I mean, I'm thinking about the difference we saw with insurance, for example, and thinking about broadband. Are you seeing some states thinking about some like systems or policy approaches to this measure as well by chance?
I can get us started in that question, which you might have to keep deconstructing for us a little bit, Sarah, because it's a good one, but I want to make sure that we're addressing it in the way that you're asking it. I mean, just based on, you know, so AMCHIP was a backbone support organization for one of the infant mortality coin efforts, in particular on social determinants of health. And, you know, and in that space, I think there's a lot of interest. It seems like there's a lot of interest, a lot of excitement from Title V programs and from their extended partners to be thinking about, to not just be thinking about, you know, once she or they get through the door, to be thinking beyond that. So not just through the door, but everything that wraps around what it means for them to be there. And so I'm seeing, we're seeing at AMCHIP, I think a real appreciation and interest in not just social determinants of health or structural determinants of health, but in the policies and practices that undergird those and keep especially racist policies and programs in place. And a desire to disrupt those. I think where it's really interesting is the translation of that interest, of that passion, of that desire, translating that acknowledgement of that accountability and of that responsibility and that power, translating that into specific strategies, that are measurable within the context of their block grant efforts. So that's, I think we're in, and what's really exciting, and I really can't wait to see what all is written and shared in this year's round of the Title V block grants and annual reports, because I think we're really at the cusp of some really interesting translation efforts in that space. So that's kind of, I know that's kind of a broad response. I don't think, you know, what some of the evidence-based strategy measures and evidence-informed strategy measures that we shared today were based off of the most recent reports. And so I think we're seeing, and I will say too, that they're based off of what we saw in the sort of specific to NPM1, but that doesn't represent necessarily where an individual state is in the other domains. And so I think we're in an interesting opportunity, an interesting place to see the translation of some of the equity foundational thinking that has been happening in maternal and infant health, but to try to actually translate that into preventive well woman visits, preventive care, whole person supported care across the lifespan. So that's kind of I think an overarching observation. You know, I'm curious if that aligns with the work of the preconception coin and that observation or observations from that space. But I'll stop there and give the floor to my colleagues and Keriann, and then yeah, Sarah and others for your thoughts on that as well.
Yeah, well, that really, I thought was a great answer. And then I think also thinking a little bit about what Kay Johnson and the other panel mentioned about also payment mechanisms. You know, so there's a whole wealth of things to consider at every single point of kind of the cascade of helping someone be able to access a visit, have that visit count and matter and uplift, and then resources to be able to act on advice that was given. So I think you're right, there's lots of different points and intersects for intervention. I'm looking at the chat, and I wanted to also shout out to Team Utah, because it sounds like you're doing a whole strategic plan about the Well Woman visit. And so I hope you'll tell us when the plan is done so we can share it, because I think I'm really excited about that. And if there's any elements of that you want to chat, that would be great. We did have a question about how folks are engaging and collaborating with reproductive justice organizations. So that kind of gets to your partnership relationship. Have you seen that happening in any of the states? And that's a great suggestion. Carrie?
I will just say Rhode Island is contracting with Sister Song, I think, they contracted with them during their needs assessment and really provided a lot of insight into their health equity work and maternal mortality work. And so they're going to continue to contract with them to support, improved implementation of their equity efforts through a variety of their programming for women maternal health.
Thanks, Keriann. That's really cool and great to hear, and something it'll be fun to follow up on more. I can just share, I think we're seeing I'd really love to hear Kristina and Giannina's thoughts on this. So I will just say at a high level, I think we're seeing a real range of partnership with reproductive justice centered organizations and community-rooted organizations that have the trust and the trust to represent Black birthing people, Indigenous birthing people, and people of color. So I think we're seeing a real range and a range in how what is the quality of that partnership, and I think a great variety of definition of what it means to partner as well. So are we talking about a single contracted funded relationship with one organization? Are we talking about uncompensated representation on task forces and other spaces? There's a really wide range, and I think Keriann starting with a really neat focus on embedding a reproductive justice organization into a foundational aspect of the Title V block grant, which is the needs assessment, is just such a cool, really important layer and level of that. But I will pass it over to Kristina or Giannina to see if they have anything else that they want to add, especially from their vantage point of facilitating so many really neat collaboratives.
I can quickly add and say that I am in full agreement that it's a variety of levels of engagement. I think you gave a great example of how the levels or the gradient of engagement changes from state to state or from place to place. I think we're really fortunate to see that some states are, doing some engagement of, really inviting RJ organizations and thought leaders to spaces that they are holding to really be partnered in like true and transparent partnership. I think I would also be remiss if I did not say that, it's unfortunate that we are presently in a world where reproductive justice, as well as its concepts and many of the tenets to that the founders of reproductive justice were intentional in including in their framework have been politicized, which impacts, I will say, how or the level of like organizational support that we can sometimes see. I'm trying to be diplomatic. I think we all understand where I'm going though. So I think that's unfortunate. It's great though to see that, again, some states are able to kind of navigate that and figure it out. work through other conveners and other people working to really help support that. And I think that we're really hopeful that we can think through how we as a support, AmChip as a support, can kind of think through and talk through how we can provide support, as well as how some of the organizations that we have been working with, how we can continue to, you know, bridge them to our partners who we know have a lot of interest.
Yeah, I want to lift up that, because I think you mentioned earlier about it's not just family planning, but it's also helping people that want to start families is really an important part of that reproductive justice continuum, as well as, I'm going to say the word abortion just because I think that's what you're trying to say, and that's just an option that many women do access who we are serving. And also wanted to lift up conversations around miscarriage as well, and infertility. There's so much loss and suffering that people face that seem like they are also certainly well placed in our expertise as maternal and child health experts as well. So I just wanted to lift that up. Wanted to note from Mch in Utah that they are, for their plan, they're looking at creating a shift in culture. So seeing that routine preventive care is self-care, which I love. It's such a show your love construct. And you know that you matter. We know that that really is important. And that they're focusing on women, providers, and the system, which I think is also a really exciting approach. Well, I just had one other question, because when Keriann was talking about performance measures, you mentioned the adolescent preventive wellness visit. And I'm wondering, is there more, and of course it's very different approach, but I'm wondering, is there evidence within the adolescent wellness visit that we can bring to women's preventive work, or are there resources, or just kind of curious if you wanted to take a minute or two to just, if there's anything you wanted to share. Do states often do both at the same time? Just curious.
I will say adolescent well visit is a highly, most frequently selected NPM, so the likelihood that, and so is NPM1. So there's going to be many states who've selected both.
And, you know, I'll just add, I think we've been, I think there's been a really exciting shift in what it means to partner with, center, and be led by youth in the space of adolescent well visits and beyond, especially in the space of mental health. And there's great collaboratives and work and efforts underway in that space. And in many ways that being led by youth is a really beautiful example or model for the opportunities for healthcare and centering women and people assigned female at birth in their care and in the support that they deserve. So I think there's a challenge sometimes with the domains, a challenge sometimes with how staffing is structured within state health agencies, is that there are silos, I'll just say, and it varies by state, but there can be silos in sort of the teams that are working and building capacity in one area, and teams that are building and working in building capacity in another area. And so it's not always fluid and seamless how the lessons across the various levels of work are shared, but there are some really cool examples out there. And some great work underway, but we have a lot to learn and all the things to be excited about for this youth leadership momentum. And I think this really beautifully follows on to questions that have been asked about partnerships with reproductive justice leaders. What does it mean for Title V to listen, to sit back, and to be led by the priorities of the individuals that this work exists for. So that's what I'll add.
I think also thinking also about how maybe the youth can, like you said, move towards this, because there's also these transitions of care. So I have two young adult children, 21 and 24, and it's confusing about when do I just stop going to my pediatrician because I can't fit in the chairs anymore, and And what does that feel like to go to a different provider, and how do I know who to find? And I know we've had people that have also struggled. So I think you're right. Like, this is also, how do we look at partnerships and relationships and think, really lean into that life course of a life of really well, high quality and person-centered care. So I wanted to lift that up. So we have just a few minutes left. Oh, yes, go ahead.
Just point out, for those who aren't as familiar with Title V, we also have a national performance measure related to improving transition to adult healthcare services as a national performance measure. So again, like, I mean, the connections are there within the guidance to be made. We have adolescent well visit, we have transition to adult healthcare services, not just for children with special healthcare needs, which is normally what it's focused on, but for all adolescents. And then we also have, leading that into adult well women care.
So I have a quick question for the folks that are listening that are not with the Title V organization, but are now very intrigued and might like to partner with them, or might have something to offer to them. Might you have suggestions about how kind of someone would know how to connect in their state with their person or this group? Thinking maybe your website.
Sorry, Sarah, was that a question for us, or was that a question for the audience? Sorry.
For y'all. I mean, if you have suggestions for them. I was just trying to think about, if they're really excited, like, I want to know about all this. I want to find these people.
I just uploaded the link to the list of state contacts on our TVIS website. So it has all the state Title V MCH directors, as well as the directors for children with special healthcare needs, that you can go and contact them.
That's awesome. And I noticed that Jill is on from Oklahoma, and we've had a chance to partner with Jill, and she works with the Title X, the family planning, and y'all mentioned that as well. So again, so many opportunities to be connecting with and partnering with Title V, which is exciting. Well, so we have just a few minutes left. I would like to go and have each one of you have a chance for a final word, thought, charge, wish.
I'll just say, from the DISH perspective, we value the longevity and stability of Title V and how it allows for, and it's structured to allow for that flexibility for a state to respond to their needs that they identify. It's always a source of great innovation because states know that funding is there, that they can try something new. It's a source of stability for states. So we're always learning from you, and it's your needs assessment greatly informed the strategic plan for the Bureau. So as much as these things are identified through the state Title V needs assessments, as well as organizations who want to partner with Title V can have their voice heard too. It's a really unique and additional power of Title V. So there's lots of opportunity.
I think I'll just echo Keriann's statements and also some of the what was shared by my colleagues earlier, that first, MCHIP is always happy to support connections, especially I'll also say internally, we are really working to center equity in our work. And we really believe that cannot be done without really transparent and intentional community engagement. And so as we're thinking about, and PM1, like this conversation about well women care, we really believe that communities need to be centered in that conversation as well. And so our ears are open, our inboxes are open, and we really want to continue the conversation of the questions that we posed here today, because exactly as you said, Sarah, earlier, there is a huge space for innovation and for things to be piloted and tried out, and for us to really rethink about how we can do things in a new way, in a creative way, in an innovative way, if we just, take that leap and that chance. So we are here and available. We want to continue this conversation. And we really want to, be in partnership with not only communities, but you all who are on this call, our fellow panelists. We really want to continue this work with you all. So thank you again for the invitation.
And then I'll just add in closing that I want to express gratitude for Kristina for cracking the door open for our conversation about abortion, and for Sarah for kicking that door open a little bit, because I felt a little bit of a pressure valve release in that. And I want to just say very much that AMCHIP, in our role as a member service organization with the state and territory health agencies, are really eager to hear confidentially, at sidebar, however we best can, what current attacks on systems of care for individuals needing abortions, what that means for you and your work, acknowledging that this is creating a landscape, especially that politicizes and fragments care further. So, and creating some really interesting things that we see of movements across different systems and across state lines, and it has ripple effects, extensive ripple effects. So just wanted to offer that in our role as a member service organization, that we're here to listen, and here to listen not just to our members, but to our the broader network of folks and colleagues about what is good public health, and how we can be best of service in this space. So wanted to lift that up and express gratitude again for opening that space, Kristina and Sarah.
I want to thank all of you for your time and energy and this really awesome conversation. And I want to lift up all of the folks working in this space. You all are innovators. This is new. We are shifting the paradigm, how to go from maternal to flipping it upside down. And so I just want to uplift that work and offer gratitude for your time. And I'm going to pass the mic back to our awesome MC.
Thank you, Sarah. And thank you to our friends and fearless leaders from AMCHIP. Thank you specifically for not only giving us an understanding of what Title V has been, what it is, and where it can go, right? And really doing the right thing here. So I am so excited that we were able to hear from your insights and calls to action. And now we'll take a quick break, and then please come back at 1:30 for our keynote session. You do not want to miss this fabulous content. Oh my goodness. The period doc, her name is Dr. Chambers, is a powerhouse of an OBGYN that is leading the way on patient advocacy, patient engagement, and supporting learning in a way that is relevant to us. If you haven't seen her video clips and various health topics, go to her website or Instagram. Find her, follow her, love her. Oh my goodness, she has a repertoire of masterpieces. You can look her up at www.theperiodoctor.com, and you're gonna hear about all of her brilliance again at 1:30. We'll see you back here in a little bit.
Thanks everyone. Thanks y'all.